So thank you everybody for showing up. And today we have Dr. Julina Nkasuwan, who's an associate professor of adult and pediatric laryngology at Baylor College of Medicine. And she's going to be talking today about vocal fold movement impairment or there and back again. Yeah. Okay, Julina.
All right. Thank you, Tulio. Thanks for inviting me. I have known Tulio since I was a little baby resident, and he was a fellow at Texas Children's. He was, in fact, my research mentor when I liked things like ears, which I don't care for anymore. But I really appreciate him asking me to come and talk to you about what I really like, which is vocal fold and vocal movement issues. So it's there and back again. So we're going to go on a little journey around the larynx, aka Middle Earth. And some of this is obviously going to be review for a lot of you, but we'll also talk about some different ways that you can evaluate the larynx and different ways of dealing with primarily unilateral vocal fold paralysis. So first of all, the anatomy. I mean, you all know this. The recurrent laryngeal nerve, though, the biggest issue is because it's this ridiculously complex nerve, right? It's not a simple nerve. It's got motor fibers, it has sensory fibers, it's got sympathetics and parasympathetics. So that's the problem. When you get a neuronal injury and reinnervation happens, because it's such a complex nerve and innervates so many different muscles, when the wires get crossed, this is where we run into problems. And so synkinesis and problems with reinnervation, I think, are really the heart of how we think of paralysis. It's not really as simple as vocal fold doesn't move. We really have to think about what sort of native reinnervation has occurred. So we'll go more into that. And then it branches when it gets into the larynx. I don't think I really even knew this till I was a laryngology fellow, the complex branching pattern of the recurrent inside the larynx. So the reason why I call this vocal fold movement impairment, we always call it vocal fold paralysis, but I actually think it's really important to keep in mind that you have to differentiate between a neuronal injury and mechanical fixation. So, this is a scope. This is a little 2-year-old I met last summer. He was a preemie, was intubated for a long time, had a PD ligation, and he was stridulous, right? He came to my office and he had this scope exam. So the vocal folds aren't abducting well, but you don't know why. So when we took him to the OR, he had this, right? He had this posterior glottic stenosis. We actually did a concurrent EMG though, and so not only did he have posterior glottic stenosis, but he also had a neuronal paralysis on the left. So this poor kid had PGS and a paralysis. And I think if you're not careful to think about differentiating the reason for movement impairment, you might not choose the right therapy for the individual with the paralysis. I think it's really important that you palpate joint mobility. Clearly, this is a different child. It's a kid with a bigger larynx. But I like to get behind the arytenoid and really push on the arytenoid. And you really want to see the vocal process moving. And if the joint is fixed, that vocal process, it feels like a rock, right? Things won't move. So part of the complete laryngeal exam should involve palpation of the joint as well. So to be clear, this talk is really, we're going to focus on neural injuries as a cause of vocal fold movement problems, not mechanical. So I'll probably say paralysis a lot, but I think it's important to differentiate the two. So you all know this, like how does vocal fold movement impairment occur? From neural reasons, surgery around the aortic arch. So this is actually a paper that Dr. Dewan did when she was a resident. At TCH, looking at the rates of recurrent laryngeal nerve injury and aortic arch surgery. It's about a third. We actually also have looked at it in our aortic population in the adults, and we found about a 20% rate of paralysis in our total arch replacements. Again, thyroidectomy, you guys all know this. And then there are the medications and weird things, infection and congenital reasons why the nerve may not be working. So why is it a problem? In infants, it can cause stridor, it can cause voice problems, and feeding is a big focus in the infant population. In older kids, like adults, it's a voice problem, difficulty projecting, and really it can cause a lot of social withdrawal. They don't want to talk, no one can hear them, and it's really, it's not cancer, it's not life-threatening, but people get, they really socially withdraw and get very depressed when they can't communicate. They can't talk on the phone. They can't talk over Zoom, Other things that can be a problem, aspiration. I put a big asterisk next to aspiration because having the glottic incompetence associated with vocal fold paralysis can cause aspiration primarily of liquids. But I'm always careful when an inpatient team asks us to do a medialization for a paralysis on a patient that's aspirating every consistency up to purees. I'm always willing to do it, but it's really important to set the expectations, right? If they think you're going to fix their swallow after they've had a big CVA, medializing the vocal fold isn't going to fix everything. So I feel like you have to do a lot of expectation setting for the families and the consulting teams. That's why I always put a big asterisk next to aspiration related to vocal fold paralysis. Impaired pulmonary toilet, we're going to talk about that more. When you can't close the glottis well, it's hard to cough out all the stuff that's in your lungs, can lead to increased pulmonary complications. And at least we found in our aortics and our cardiac babies that it does result in increased lengths of stay. So the types of injury, this is, basic stuff back to medical school, but it depends on how badly the nerve is injured, the degree of injury, that can then play a role in the recovery after injury. So it depends on whether it's the endoneurium, the perineurium, the epineurium, which of these are violated. And that then has implications in prognosis. So let's say you cut a nerve. What happens? You get wall area degeneration of the axon back to the cell body. If no reinnervation occurs, you're going to get atrophy, which can occur as early as 6 weeks. But more frequently, what we found is that reinnervation occurs. The nerve wants to grow back, right? It really, really wants to grow back. But again, the problem with the recurrent is this ridiculously complex nerve, right? So if you were to get recovery of full motion, ideally your adductor nerve fibers have to find those adductor muscles, and your abductor nerve fibers have to find your abductor muscles. And that's more likely to happen if you have a lower grade injury and the axon is still largely intact, or at least the nerve sheath is intact. It's less likely to happen if it's been cut, and oftentimes the nerves get crossed and you end up with synkinesis. So Roger Crumley has written a series of papers on his theoretical framework for thinking about synkinesis. He divides them into 4 types: this favorable, and then he groups them into favorable and unfavorable. So the only favorable one he calls it type 1, where the vocal fold is immobile but largely midline, and the voice and airway are good. And then he subdivides them into 3 unfavorable subtypes. That, if the vocal fold is lateral and the voice is crummy, or if it's super hyperadducted, so that when they try to breathe, they have adduction and may have some airway difficulties associated with that, or if it's hyperadducted. Again, this is Roger Crumley's theoretical framework for this. I confess I don't personally classify synkinesis this way. When I look at the vocal fold, I'm much more simplistic in the way I think of it personally. So I usually use vocal fold position when I'm just doing a laryngoscopy. And oftentimes you have this lateral or cadaveric or completely denervated position. And this is oftentimes the acute paralysis. They cut the nerve and you have this huge glottic gap. They're super breathy and out lateral. And then over time, some spontaneous reinnervation occurs, and the vocal fold will either be in this paramedian position or in this median position, and the voice will reflect that in the degree of glottic gap they have. So I confess this is how I look at vocal folds more so than using Crumley's synkinesis classification. So moving on to diagnosis. So flexible nasal laryngoscopy, you all know this. This is the way that we look at vocal fold mobility. But I don't know about you guys, but I don't particularly love being scoped, and I don't love scoping little babies because they scream so much. And kids, it can be tough. You can take 3 people, right? You've got someone holding the body, someone holding the head, and you're holding the scope, and it's just really unpleasant. And I hate crying. basically. So we actually looked at this. We studied the inter and intra-rater reliability of flexible scope in infants. And we found that actually our inter-rater reliability was not that great. Now, granted, we were looking at these totally blinded, no history. We're trying to take out any bias, anything that would give us bias. There was no sound either. But just looking at the scope, we weren't that consistent with one another at identifying mobility, which means that we don't get a really good view, I don't think. And we tend to use a lot of other data to try to make the decision, like what the history was or how their cries sounded. Uh-oh. Oh no. My computer's frozen. It's thinking, oh no. Well, so my PowerPoint is crashing, guys. I'm so sorry. Launch that. Okay, give me a sec. So, share screen, share PowerPoint, share. Okay, so in the clinic, I actually use quite a bit of rigid transoral laryngoscopy, which I find that there's a lot less crying. We actually looked at our success rate. I'll do it in kids up to or down to age 3. And what I actually use, it's a 70 degrees sinuscope, pediatric sinuscope with the light cord reversed, so it comes off the bottom instead of the top, so you can look down instead of up. And kids do great. It's actually, I think, easier than adult transoral laryngoscopy because the larynx is so high on these kids. Sometimes you can see their epiglottis when you look straight in, and you can get really great stroboscopy with very little crying because I hate making kids cry. We've also been playing with some VR. I know you guys have done some of this up here, up at Stanford. We've been playing with VR. I don't find it helps that much with flexible scope in the nose with kids, but it really helps actually with this transoral scope for some of the kids who are kind of squirmy. It works pretty well. So one of the other things we decided to look at, you know how I mentioned that sometimes I think just the visual laryngoscopy itself sometimes we don't always agree because I think we use these other cues such as the cry characteristics. So we actually looked at that as well. We actually just used a decibel meter app on our phone, on an iPhone, and we stuck it next to the baby while we were scoping them. Because everyone knows what a paralysis sounds like, right? The cry is rough, the cry is weak, but we were trying to give the bedside nurse, the non-experienced listener, something to use to know when to call us as a screening tool for vocal fold, some glottic incompetence or vocal fold problem. And we found, there's a difference in their cry volume, right? And then we did some rock curves and found that there was a difference between them, and we could use this, and we use a cutoff of about 75 decibels. If their cry strength or cry decibel strength is less than 75 decibels, it's pretty specific that there's going to be a vocal fold weakness there. Again, this isn't really for us, like the experienced listener. It's more for a inexperienced listener, like a bedside nurse, to say, hey, maybe it can be used as a screening tool. Laryngeal EMG, I use this. I actually love laryngeal EMG. I do it awake in my adult practice. I also do it in my peds practice. Things we're looking for in laryngeal EMG. I mean, EMG can be a talk in and of itself, but I'm going to give a quick sum up is you look at different things. You look at involuntary potentials and you look at voluntary potentials, right? So the involuntary potential is one of the first things you look at when you stick the needle in, is you're looking for insertional activity. because when you stick it in, you're gonna irritate the muscle, and there are going to be some depolarizations. And in previously, in the setting of neuronal injury, you may have prolonged activity beyond just needle insertion. And then you just sit there. You stick the needle in, your spontaneous activity occurs, and then you sit there and you wait. Your insertional activity. And then you wait to see if you have spontaneous activity. So examples of spontaneous activity include fibrillation potentials, fibs. These are these things that classically sound like rain on a hot tin roof. Positive sharp waves, which are these downward deflections on the EMG. These are just signs of these are denervation potentials. These are signs that there's not nerve innervation there. And they're kind of like there's irritability of the remaining muscle, the muscle that's there. And then we also see a lot of CRDs, these complex repetitive discharges on our pediatric EMGs, which is, I don't really know why we see these a lot, but this CRD is an electrical reentry loop. I tell my learners, I call them the WPW of the motor end plate. It's basically the motor end plate, it's a reentry loop. The signal is just going round and around and around without a nerve axon. And it sounds like zzz, it sounds like this machinery, harsh sound. It's very interesting. I don't really see this that often in my adult patients, but you actually see it in the pediatric patients, and I don't, again, really understand why. And then, ideally, you ask them to phonate, and you look for voluntary activities. So this is like what a normal motor unit action potential looks like. And then in the setting of a previous nerve injury that has now had spontaneous reinnervation, you'll see these reinnervation potentials. So if you imagine that your axon got cut, you had Wallerian degeneration back to the cell body, then it grew back, right? But not all of your axons grew back. So if you say your normal axon innervated 5 little muscle bundles, your one nerve grew back, but now it's trying to innervate 10 muscle bundles, but some of them are further away. So that when you have your depolarization, the muscle bundles aren't, when you have your nerve signal, you're not having this neat, tidy depolarization of this quite tightly grouped group of muscles. You're having depolarizations happening slightly at different times because it's innervating a bigger group. And so your action potential that you'll see may be bigger, taller, or giant action potential because there are more muscle bundles. And it looks messy. It's called a polyphasic potential because it has multiple phases instead of this neat down, up, down. It goes squiggle up and down all over the baseline at least 5 times, and that's a polyphasic. And a polyphasic potential just means you had a neuronal injury and some reinnervation occurred. So they're reinnervation potentials. So again, the EMG, like that kid I was telling you about, is totally helpful for me to say, hey, this was a neural problem, or nah, the nerve is fine, maybe there's a mechanical issue in there. The harder you activate, the more action potential, motor unit actions are going to get recruited. This is recruitment. So like it's trying to contract and it wants to contract harder, it will recruit more of its friends, more action potentials to come together, and then your motor action potentials are going to start overlapping each other, called an interference pattern, and basically you start not being able to see the individuals, and it just looks like a big forest of depolarizations. And that's recruitment. And if you've had a previous neural injury, you just have fewer axons to activate, so your forest looks a lot more sparse, and so you'll have a much more sparse looking interference pattern in a setting of neuropathic injury that's occurred. So those are the different things we look for in EMG. Now the problem with kids is that most kids aren't going to just stick a needle in their neck and phonate. So that's a limitation. So I do my pediatric EMGs in the OR under anesthesia, but we do it under spontaneous tubeless ventilation, and they have to be kind of light because you really want to see the vocal folds moving. And I am really looking at the PCAs. So I put it in the PCA, and you should hear the motor units firing with respiration. So we look at their chest, we look at their respiration, and you hear these depolarizations, and that's normal. And then, we'll go to the not good side, and then you'll either hear polyphasics or you'll hear all these spontaneous potentials. And that's how we look at it. It can be tricky though, because you have to make sure that the child is at the right phase, that they're light enough, that they're breathing well enough. Because if they're super deep and they're not taking good breaths and the larynx isn't activating, it could be a false positive. So we actually spend a lot of time kind of making sure they're light enough till they're almost coughing, to make sure that the EMG is accurate. I will also test the TAs as well to look for true synkinesis, and sometimes we'll see it. The TAs should be silent with respiration, right? But sometimes we'll see activation of the TAs with respiration, and that represents, true backwards aberrant synkinesis, which is sometimes just neat to see. And then laryngeal ultrasound. I think you guys are already familiar with laryngeal ultrasound because I know Doug Seidel's been doing them, but I can tell you really quickly, it's not new. It's been around since the 80s. I think that ultrasound technology has come a long way. I think that's why it didn't really take off when it first came out in the 80s. I think ultrasounds were big and expensive, and the image quality was kind of tough to interpret. The adult endocrine surgeons have been using laryngeal ultrasound, and there's data from the adult world. You'll see kind of wide-ranging sensitivities and specificities. And clearly age is a problem, body habitus is a problem in older individuals. So we actually looked at this using CT because we were kind of curious, like how does the larynx calcify? When does it get too dense for us to be able to penetrate through to see the vocal folds? And we found, at least in our data, that it was around 40 plus or minus 7 years that that cartilage got really calcified and it was hard to see through. And that's kind of been our clinical experience as well, that the older it's just hard for us to see the endolarynx. At least in our practice, we use either somewhere between a 12 to 15 megahertz probe. I think when you turn down the megahertz, it really lets you penetrate deeper into the larynx, which is helpful for big adults or if they have a lot of soft tissue overlying the neck. But you get loss of resolution. You may be able to see gross movement, but seeing anything more detailed, I think, becomes very challenging when you get down to 5.85 megahertz. And then again, gender may play a role. BMI, it's hard to tell in adults. I actually think pediatric laryngeal ultrasound is way easier than adults, especially infants. Their necks are so thin, you're really able to see the endolarynx really well. This was a study we did. This was actually my trial thesis years ago, where we, did scopes and laryngeal ultrasounds on a bunch of kids, and found that we had really good agreement between the two, and they tolerated the ultrasound much better than the flex scope. I mean, kids will fall asleep sucking on a pacifier when we're doing this, and you got to wake them up to really see movement. And I think Tulio may have shared with you guys, I made this video, just a training module to practice laryngeal ultrasound. And if you want to try it, just to learn how to do it. I will say we put measurements in there. That's really something that the radiologists really wanted. They like to measure things. I'll be honest, in my practice, I have an ultrasound in my office. I ultrasound almost every kid that comes through. I don't bother to measure the angles. I treat it more like we treat a flex scope, and I eyeball it. And I think we are more comfortable with that as otolaryngologists. I've just found the radiologists I've worked with and tried to train really weren't comfortable with that. Moving on to management, we're talking primarily about unilateral vocal fold paralysis. And so why do we medialize? I mean, we all know this, to try to help their voice, improve glottic competence, to help with swallowing with the giant asterisk that it helps primarily with liquid swallowing. If it's solids and purees, there's a little bit more to it. and pulmonary toilet. I think this is a big thing that I didn't think about when I was a trainee, but I do think about a lot now. This is the one that we are called for the most in the inpatient setting, especially in our CVICUs. So we've actually looked at this. We've actually looked at it. We do it on full anticoagulation. We'll do it on Coumadin, on Plavix, the works. I don't take it up. We just roll our cart up to the bedside, and we'll do our injections. And we found that the earlier we do it, the better, and we're able to even to decrease their pulmonary complications. And so this data is primarily in type 1 and extent 1 and extent 2 aortics, but I do this for basically anybody who may have impaired pulmonary clearance at the bedside in the adult population. Now, I'm not doing this early injections in infants. I know Doug has been. We just haven't gotten there yet at children's. And my adult patients, I do it all the time because I don't have to put them to sleep. I just numb them up and do it awake at the bedside. We're just not there yet, taking these kids to put them under anesthesia to medialize, but it's a good area to look in research-wise. The question is also, when do you medialize? So clearly I do injections super duper early. I'll do injections, the day they're extubated. But when do you do a permanent procedure? Ted Mal published this paper back in 2017 that I thought was really interesting. And he basically came up with this sort of theoretical framework construct of how to think about vocal fold recovery after injury. And, we're all taught, you wait a year, just wait a year till you do anything permanent. And what he found in his model and looking at his patients is that it's probably a lot sooner than that we can, that most people recover. And he found that there's this bimodal distribution of recovery. So this was the theoretical framework in this slide. And this early group probably corresponded to neuropraxia. The axon was intact. So they recovered really early, like in a matter of weeks. And that this later group, this group B, C, really correspond to the axonomesis, maybe the neuromesis groups, where the axon is disrupted and they have a longer phase to recovery. But then he modeled, he put his patient data in, and it did concur with his theoretical model. But you'll see that the vast majority, when you get to the tail end of this distribution, the vast majority are getting better by 30 weeks, 40 weeks, which is, 6 months, 9 months, much earlier than a year. So it really kind of changed the way I think of it. So I actually take into account age as well. So I will do thyroplasties in my older patients as early as 6 months now, if they show no signs of recovery. So I think it's kind of changed the way that I think about when to do a permanent medialization procedure, at least in my adults. In kids, I am still waiting at least a year, sometimes longer. So how do you medialize? So, injections I mentioned, I favor a thyrohyoid approach. And again, this can be a whole talk in and of itself. I'm going to skip ahead so you can see is you come in at the thyroid notch and the needle comes out the petiole. You have to get them pretty numb. I usually nebulize them first, and then I atomize them a bit, and then I drip some lidocaine directly on. And then I just leave the needle in place, and I actually use a spinal needle, and I leave it in place. And I really like it because you can it's like doing a per oral or like an injection under anesthesia. You can really control where the bolus is going. There's also transoral approaches. This is a cricothyroid approach. You're gonna have to forgive the blood in the airway because I really only do per oral approaches when I fail at the thyrohyoid approach. So there shouldn't be blood in the airway. It should be an all submucosal approach. So you don't actually see your needle when you do this. And then another way you can do it is with a channel laryngoscope. So you can theoretically do injections through a channel laryngoscope. This is an example of a patient I do Botox with, and he, for some reason, I can only do it with a channel laryngoscope. But there are lots of different ways to do it, and I always tell people is you just figure out which way works best for you and get really good at it. But I do 99.9% of my injections through the thyrohyoid technique. And then when you're under anesthesia, use different anesthetic techniques. Laryngeal framework surgery, type 1 thyroplasty. Again, this is just a little video, but you basically drill a window and then elevate a sub-interperitoneal flap. You make a little pocket, and then you put your implant of choice in there. You can put Silastic, you can put Gore-Tex, you can use the prefabricated implants like the Montgomery system. There are lots of different ways of doing this. Type 1 thyroplasty, honestly, this is how I fell in love with laryngology, because it's the coolest surgery ever, because they're awake and you can get an immediate result, and you can, like, you're pushing on the outside and you're looking at the scope that's hanging in their nose on the inside. This was my favorite surgery when I was a resident. It's not my favorite surgery anymore. So my favorite surgery now is the laryngeal reinnervation. So when I talk this section, I'm really talking about the non-selective laryngeal reinnervation. So I categorize this as a medialization procedure. It is not meant to restore movement. It's really meant to restore bulk and tone to the vocal fold. It is a medialization procedure. And there have been lots of different types of laryngeal reinnervation procedures described in the past. So what I do, and what I think most of us now do, is a pretty simple, you take the ANSA and you hook it up to the recurrent laryngeal nerve. And you just do a single end-to-end neurophy anastomosis. This is a picture of it's actually an 18-year-old that had a head and neck cancer surgery, and they knew they were going to sacrifice the vagus. So my head and neck partners invited me in to do a concurrent reinnervation, which is like, it's the best time to do it, because you don't have to go back into a previously operated neck. And so I don't usually do my reinnervations through this giant incision, but we were so proud of ourselves that we dissected out this beautiful ANSA, and I got to feel like a real surgeon. So anyway, that's my picture. There's a picture of a giant hole in ANSA. So why choose a reinnervation over a thyroplasty or static medialization? What I think is one of the big advantages is that one of the challenges with a thyroplasty, and why sometimes you have to use the arytenoid adduction, is getting that posterior glottis together can be a challenge. That arytenoid has to rotate medially and often down a little bit as well when we phonate, and that is difficult to reconstitute with the static medialization, and you don't have to worry about that as much with the reinnervation. So improving the posterior glottis. One of the big concerns for putting an implant in, especially if the vocal fold is really atrophic, is if you can change some of the vibratory characteristics and pliability of the tissue with the thyroplasty. You don't have to worry about that with the reinnervation. You don't have to worry about continued atrophy, ongoing atrophy, because in theory, you're going to help reverse some of that atrophy and keep some bulk in the muscle. Synkinesis can be a problem. Like if they have really bad aberrant synkinesis, you're not addressing that with a thyroplasty. Whereas with the reinnervation, because you're denervating that side of the larynx again, you are able to address that synkinetic aspect. One of the big downsides is it's not instant gratification surgery, and so the patient and their family have to be okay with it's going to take 4 to 6 months to start seeing a result from the reinnervation, up to a year to see the final result. I do typically do an injection at the time of reinnervation to help with that. to help them get a little bit of a boost since they're under anesthesia, and it takes a very short period of time to add that. For static medialization, if you're talking about an injection, those are temporary. Reinnervation, as far as we know, are permanent. You know, I don't think people have been doing these in large numbers for very long to know what a reinnervated larynx will look like, you know, 10, 20, 30 years later. So that, as far as we know, should be a permanent procedure, barring an additional injury. And then the big downside in children, of course, is they grow. And thyroplasties need to be revised as kids grow. And I have revised thyroplasties in kids. And that's not ideal, and haven't had to, and in theory, the reinnervation should grow with the kid. Won't need to revise it. So, you know, nothing is new in the world. So reinnervation has been around for a really long time. The first report, this is actually a neurosurgeon. The first report was in 1924. You know, Harvey Tucker published a lot on laryngeal reinnervation, and as did Roger Crumley in the 80s. So it's nothing new. I think it's just picked up a little steam, especially in the pediatric world. But I do think one of the things to keep in mind is that, again, it's a medialization procedure. If you're expecting motion, you're going to be disappointed. And I really think that expectation setting for this is really, really, really important. So to take you through a reinnervation, this is now my favorite surgery. This is playing. I actually generally will do it at the same time as a laryngeal EMG, and like I said, the injection laryngoplasty. So this is how we do the EMG in children. You can see this needle here. It's a monopolar needle. I stick it into the PCAs, and then I also do it in the TA. And I actually do it with a PM&R doc who interprets the EMG for me. So I stick the needles in, and she does the interpretation. And then I combo it with an injection laryngoplasty. When you're doing the PCA EMG, one thing to keep in mind is there's actually a plexus of veins back there, and I've had a hematoma before back there that I just popped and let it drain, but it can bleed if you hit that little plexus. So so this is how I really do the EMG, through a teeny weeny little 2 centimeter incision in the neck, not that big giant incision. At the beginning, I usually will harvest a little bit of an anterior jug or external jug, and I'll save it on the back table to use as a conduit to cover the anastomosis later in the surgery. You can buy the expensive stuff to cover the anastomosis, but I think free vein works pretty well. Then you make an incision in front of the SCM, pull the SCM back, and I usually mobilize the omohyoid, and then you'll find the ANSA right on the omo. So when I was first doing this, you know, we never really look for the ANSA in head and neck surgery, at least I didn't. And we would, you know, just cut it. And so I was super nervous when I first started this, and I would think every little white strip was the ANSA, and I would stim it all over the place. And then finally I just learned, just get straight out into the OMA, elevate the OMO, look underneath, and the ANSA is always there. And then I stick a little vessel loop around it to mark it. I don't cut it until I have found the recurrent. So I like to find the recurrent under the thyroid. And so since we're working in this teeny weeny itty bitty incision, I actually usually have to mobilize the thyroid and then actually pull it out of the neck to get it out of the way and find the ANSA there. Or, I'm sorry, and find the recurrent there. And then I look at both of them and I try to figure out which one is going to be the best size match, and then put them in approximation. Then I thread that vein that we saved from earlier onto one side, and you do your little neurophy. It's not always this bloody, which is probably not a good one to record. I use 9/0 nylons. I do 3 epineural sutures of 9/0 nylon. Doesn't have to be super tight. You're just trying to get them to approximate. And then oh, sorry, I don't know what happened there. And then You just get them together. And then my very favorite part of the surgery is you take the vein, and I call it the little hand muff. It's your little hand muff, and you slide it over the anastomosis. And I don't know, it's my favorite part of the surgery. I think it's really cute. And that's it. I don't put a drain in. For the little kids, I keep them for 23 hours. Actually, my adult patients now, I started sending them home same day. And it's really great. So what's the data on laryngeal reinnervation? The biggest series that have been published are out of Shanghai. And these are adult series. These are adult patients. And the sum up is that they found it worked, that the voice outcomes were generally quite good with these. Their data was that in the adult literature, that it worked best in individuals under 60 years old and best if done within 2 years of surgery. These are 3 different publications, but often the same group. This was a really landmark paper that was published by Randy Paniello. This was a multi-institutional study where they actually tried to randomize adult patients into either laryngeal reinnervation versus type 1 thyroplasty. Now, the study in the end was quite underpowered. It was woefully underpowered, so you have to take it all with a grain of salt. But one of the things that kind of was noted is that the laryngeal reinnervations in patients who were under 52 had the best voice-related quality of life, had the best perceptual outcomes, as well as objective outcomes. Now, these are capsular peaks. So based on this study, again, it is underpowered, but I do think that is that the age plays a role. And based on this and on the data from Shanghai, I personally offer laryngeal reinnervation to anyone under 55 who have neuronal focal fold paralysis. And that's just been my practice pattern. This is our data from Texas Children's. This is our first 32 patients. And we measured voice-related quality of life, perceptual eval, we used the CAPE-V, and then we did objective evaluation, including capsular peaks as well. And this is the long and short of it, is it totally works. It works. It's my favorite surgery. The parents come back, the kids are so loud, everyone's happy. The parents are asking me if I can make the kids quieter. It's my favorite surgery. Now, it doesn't work all the time, though. I mean, no surgery works all the time. But here's some voice samples. This is a 2-year-old. He's a preemie, PDA ligation, vocal fold paralysis, and this is his pre-op voice. As you can hear, I love my SLPs. They're really awesome. Sometimes getting voice measures in little kids can be tough. You have to get creative. So these are his post-op measures. So, I love it. We get like these wonderful, near just about normal voices. That Shanghai data said that they got the best results if done within 2 years of surgery. I will say in the peds literature, I have done this up to 26 years after injury. It's a 26-year-old who presumably had the injury as a neonate, and we're still getting good voice results. So this is a 16-year-old who again was a preemie PDA ligation. And this is her post-op. But one of the things we do find, and this is true of this particular girl, I remember her really well, is that sometimes they've become so accustomed to this weak and breathy voice, it's become so much of their identity that even when they have this great post-op voice, a lot of times they are self-conscious, it doesn't feel like them, and they don't want to use it. And our older kids often need more voice therapy to get comfortable with their new voice, to see it as part of them. I remember our SLPs taking this girl down to the cafeteria in pre-social distancing time and like trying to make her get loud to order food at the cafeteria because she had this great voice potential, but she didn't feel comfortable with it. We needed some voice therapy to get there. We don't find that problem in the little tiny ones. Okay, but like I was saying, it doesn't work. It's not perfect, right? And one of the things we were trying to figure out with this study is, who are the kids that this works for and who are the kids it doesn't. So we tried to look at a couple different variables. We looked at age, at the time of reinnervation, we looked at the duration of the paralysis, and we didn't find those to be variables. Different from the adult literature, different from what that Chinese, the Shanghainese paper showed. But we also did laryngeal EMG on all of these patients pre-op, and what we found was that the EMG did show some differences between. So I basically classified the EMGs into two groups, simplified it into two groups. One was if there were basically electrical silence or only denervation or spontaneous potentials, fibs, positive sharp wave, CRDs. And then that was one group. And then the other group was patients who had evidence of spontaneous reinnervation. They had polyphasics or other reinnervation potentials in their giant motor units or whatever. And what we found was not what I was expecting. What we found was that if they had signs of spontaneous reinnervation, their voices were worse after reinnervation. That those patients that had denervation potentials did better, which is actually not what I was expecting to find at all. And my theory now, maybe, is that maybe if they've had spontaneous reinnervation, maybe they had collateral sprouting either from the SLN or maybe the contralateral RLN, which can occur, that maybe the motor end plates are occupied and not available for our new axons with the reinnervation. I don't know, it's all theory. But it was an interesting finding, and again, not really what I was expecting to see, but that's what we found. Another variable we did look at in the paper, which wasn't significant, but I do think we need to take into account, is this posterior glottic insufficiency, which again, something I didn't do a good job thinking about earlier in my career. But if you see this in kids who have normal vocal fold mobility, but also in kids with paralysis. But these are our preemies, our teeny weeny babies who are intubated for a long time, the same ones that get the PDA ligation and a paralysis. But you can basically see is that tube can erode away the vocal process, and you end up with these troughs, these furrows within the vocal fold. And on scope in the office, they may look fine because that area is obscured by the arytenoid, but they sound horrible. Like the vocal folds may look fine, the closure anterior looks fine, but then you get in the OR and there's this big divot. So I feel like I was not appreciating that well earlier in my career, and I'm realizing it's more and more of a problem. And I've been working on trying to develop some mucosal rotation flaps to try to fill in those divots to help with the posterior glottic insufficiency. Which of note is, I think it's different than the posterior glottic diastasis that you see from a posterior graft. Like you put a posterior graft in there on an airway reconstruction and you push the arytenoids further apart, that's diastasis. This is not diastasis in my mind. This is insufficiency, like there's cartilage missing off of the arytenoid because it got eaten away by the tube. At any rate, I think this is an area that at least I find interesting and looking more into. And then finally, what about the bilateral vocal fold paralysis? And this is paralysis, not posterior glottic stenosis, not the PGS that we looked at earlier, but paralysis. What can we do? So Jean-Paul Marie in France developed this selective laryngeal reinnervation. So it's different from the non-selective ANSA reinnervation that we've been talking about. So this is a patient of mine. She's actually 54, here. She had a total thyroid done by one of our endocrine surgeons, and obstructed right after extubation, had an emergent trach, and then sent to me. So you can see she really doesn't have any rotational movement of her arytenoids. So I sat on her for a year, and then I convinced her that to let me try this selective reinnervation on her. So what you do in this surgery is you take an upper rootlet of the phrenic, and you take a jump graft. Jean-Paul-Marie uses a greater aric. He traces the greater aric up into the parotid where it starts to branch. So you use that branching pattern, and you implant the greater aric directly into the PCAs to give you the abduction. So you tunnel it behind the carotid into the posterior larynx. And then to get the adduction, you take this thyrohyoid branch off the hypoglossal, which I was calling the imaginary branch because I was like, I don't believe this thing exists because it's so teeny weeny, but it totally exists when you look for it. So you take this branch to the thyrohyoid muscle, and you jump graft it using some ANSA or whatever nerve you can find, and you jump graft that to the main trunk of the recurrent. And for her, she was a total thyroid, so to find the recurrent, we had to open the joint and find it inside the larynx. And you do an end-to-end anastomosis. So it's a much bigger, more complicated surgery than just the ANSA to RLN. But where the ANSA to RLN is really a medialization procedure, this procedure is theoretically supposed to restore movement. So this is her at 1 year post-op. So she moves, she abducts, she adducts. It's not normal. Right? So it's not totally normal, but she moves. And I wasn't even sure it was going to work, but it totally, she moves. So I think that's really exciting for restoring movement for bilateral paralysis. So what's next? I know we're running out of time, I'm sorry. So nimlodipine, people have been trying to use nimlodipine to encourage reinnervation. I have actually not, I haven't tried it yet in my practice, but that has been done. I think Clark Rosen published a paper on that. People have also tried doing muscle stimulation, again, to encourage reinnervation to occur into the TA. Again, we're back at unilateral paralysis, but to encourage TA reinnervation, so that medialization. People have also tried blocking the PCA. Again, we're talking about unilateral paralysis here, so that your spontaneous reinnervation that occurs all goes to your adductors and doesn't go to your abductors. And that's why I named this there and back again, because fundamentally everything is about reinnervation and synkinesis. Again, vocal fold paralysis isn't just deinnervation and flaccid paralysis, it's really about synkinesis. But anyway, that is the end for me. We are so happy that Dr. Messner has joined us, because clearly we have a lot of fun down in Houston. I'm sure she had fun with you guys at Stanford, but we're more fun down in Houston. And this is our air digestive team at Texas Children's, and these are my two little munchkins. And I know it's getting close to 7, but I don't know if you guys have any questions. And that's it. That's what I got.
Hey, thank you very much, Jelena. It's Kwong again. There's so much good stuff in there. Actually, I have a whole bunch of questions, so I might dominate questions for a little bit. I guess I'll start with the first. Again, I missed a little bit of the beginning because I was on the tumor board call, but you mentioned Ted Mao's study and starting to do framework surgery earlier. Are you only doing thyroplasties, or are you doing arytenoid procedures at 6 months as well? Because I have done thyroplasties early, but I'm reluctant to do an arytenoid procedure at 6 months.
So I concur because I still worry if they are going to get moving. If I've lassoed their arytenoid, am I going to screw that up for them? So I haven't. And I haven't, in short, done the arytenoid procedures early. But I have, I've started doing thyroplasties early because
Are you doing?
Sorry, go ahead.
Are you doing EMGs early and deciding, even before 6 months?
I haven't done it before 6 months. I have not bit the bullet. I haven't. No. Are you? Are you doing them early?
I've done it a couple of times when somebody really wanted done early. I got an EMG and saw no electrical activity, and we went ahead and did a thyroplasty early. Yeah.
Yeah. Do you know what happened to them long term? Did they get?
Well, they did fine with the thyroplasty, but
right.
I'd never EMG'd again.
Well, when I came back, when I was a resident, Dr. Donovan, who's our chair, had been doing early thyroplasties for decades. And I did it, and he did inpatient early thyroplasties on the aortic patients. So really early, like a week after injury. And so that's what actually I did in my first year of practice till they got used to me and I could switch to doing injections. And I always wondered, he didn't do arytenoid deductions, it was just thyroplasties, but I follow these guys now and a lot of them get better and don't need any medialization. So there are people walking probably around with an implant with,
Yeah, and theoretically that's reversible, right? You can take it out.
Right, you can pop it out. It's just different practice,
Does anybody else have any questions before I ask another? All right, so I will jump in again. So I actually very rarely do reinnervations. I think mostly because I see probably older patients than you do. But we actually just saw one the other day, the 19-year-old that had resection of the recurrent after thyroidectomy. She had a previous contralateral parotid muco-ep or something like that she had taken out and had radiation therapy for. So I am going to offer her reinnervation if she wants it.
Right.
How often do you go into a previously operated neck and have trouble finding either an ANSA or the stump of the recurrent?
So the ANSA, like if they've had a neck dissection, or like for me it's more like carotid body tumors and things like that, I don't even bother going on the same side. Ideally, I'll just go to the other neck, and hopefully the other neck has not been operated on, as far as the ANSA is concerned. Because, we all did head and neck. We used to bag the recurrent all the time, not the recurrent, the ANSA all the time. You cut it, it jumps, you're like, oh, there it goes, So my assumption is that it's cut, it's gone if someone's had a neck dissection. So ideally, if you have a contralateral neck, I would go to the contralateral neck.
So the other side, they did the thyroid on the other side, right?
So
and a parotid on the other side, and radiation.
You should be okay. Okay, as long as they're not doing a neck dissection, right? Just the thyroid. They're going to do central compartment. Right?
I'll have to go back and look at the operates. Yeah, and see what happened.
I haven't had the situation where both ANSAs were taken, I'll be honest. And then to get the recurrent, I do it the way, like I was saying, I actually will take the constrictors off the bottom of the thyroid cartilage, pop up in the joint, and I'll find it right under there.
Inside.
Yeah, and I've done that a couple times. Like if it's after a thyroid, I don't bother digging in the scar. It's too painful. I don't even bother. I just go open it up.
Great, that's a good tip.
Yeah, too much pain.
My next comment is on the, your study where the people that had electrical signal on EMG did more worse than the people that had no electrical signal. I agree. It's probably some reinnervation from the SLN.
Right.
Have you thought about maybe trying to go find the SLN, maybe give a little clamp, pinch with your clamp and see if you could denervate and encourage reinnervation?
I have never thought of that. That is a good thought. Maybe I'll try it. But then I have to make my incision bigger. I like making my fellows work through this teeny weeny incision. just enjoy making them do that.
Right. But if the motor end plates are occupied already,
Yeah.
then you're not going to have much effect
Yeah.
when you do that reinnervation.
Right. I was surprised to find that result. That was not my working hypothesis going in.
Right.
And I think that's a good thought. I have not tried that. One thing I haven't mentioned that I have been thinking of trying is I went to a talk that a plastic surgeon did who does peripheral nerve, and she did ocular stuff. But she describes doing an end to side for paresis. They call it a supercharge reinnervation. So like I'm always worried about folks that they have actually an okay voice, but like I always feel great doing a reinnervation if they have a crummy voice, right? You're going to make them better. But the ones that are kind of in between, right? Those paramedians are pretty good, but they're not quite there. I tend to put implants in, right? Because I don't want to cut what they have. And so what she was describing in the plastics literature is they will do an end to side to just get a few more axons going in there, which I think is interesting. I haven't yet tried it, but I think it's an interesting thought. Except if your motor end plate's already occupied, I don't know how much it's gonna help, but I haven't tried it yet. It's just an interesting thought. So I don't know. There's some questions here in the chat too. After reinnervation, you get more synkinesis in adults than you do in children. I haven't found it to be that much different. Microanatomy of the RL end. Is there fascicular bundles of various fiber types or two muscle groups? My answer is going to be, I don't know. That's my answer. I'm sorry, Maroon. I don't know if the different, like if you're saying the PCA, if it has a different different vesicular fiber type versus like fast twitch, slow twitch versus the TA. Now there is data on that, and I think I showed that in the one of the first slides, that there are differences when it comes to that, but how that impacts reinnervation, that I don't know.
How many of those bilateral selective reinnervations have you done now? Well, that's one more than I've done. So Jelena and I were in Rouen, France, taking the same course at the same time, and you can see who has more guts than the other.
I've only done one. I keep looking for another one, but yeah, it's patient selection, right? It's got to be the right patient. They have to be young. Ideally, you got to know the mechanism of injury, no PGS, and I was totally open with her. I told her, like, I've never done this before. Are you willing to give it a go? And she was willing. I was like, this is a crazy surgery, and she said, go for it. And I said, okay. And it worked really well. But
did you have any help?
So actually, I had Kate Heathcote fly in. So what I did, because I am paranoid, right, is because the imaginary thyroid branch, I was like, this thing doesn't exist. Even though we did it on the cadaver, I still wanted practice. So I actually scrubbed some laryngectomy neck dissections with my head and neck buddies. So in the months before, I would scrub with them and just practice some of those specific maneuvers that we don't do very often. And then I had Kate fly. I flew Kate over, and she was one of Jean-Paul Marie's fellows. Her English is just better. I had difficulty understanding Jean-Paul Marie. And then we did it in the cadaver lab the day before, twice on 2 cadavers. And then she couldn't scrub in the OR, but she kind of stood over my shoulder and gave advice. And then I actually did it with one of the head and neck guys, which I think made it a lot faster. So instead of a single surgeon going back and forth over the table, I did one side, he did the other side. I'm left-handed, he's right-handed, so it worked out really well. So he did the neurofees on his side, on the right side. I did mine, I guess he did the left side, I don't remember. But he did neurofees on one side, I did the neurofees on the other. And we actually got it done relatively fast that way. So it worked really well. But I practiced a lot because it's something we don't do.
Yeah.
And then
well, congratulations, that's a great result.
Thanks. I just want to do it again.
right, I'll stop asking questions now. I think Varun put a follow-up in.
Yeah. Do bundles travel all mixed, or are there bundles within the nerve fibers? I'm sorry, I don't know, Vern. I don't know. Maybe you can find out for us. I don't know what the answer to that is. Y'all have any other questions?
Well, Julina, thank you so much. Once again, it's great to see one of my former residents now to a superstar. So great to see that.
Thanks for having me. Appreciate it, guys. Hope it was helpful. Yeah, I guess you can always email me or call me. These guys have my email, my cell phone number if you have any other questions.